all. This is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. So today we will present a study from Germany. This is an autopsy-based histopathology of the cardiac tissue of the individuals who died within 20 days after receiving the messenger RNA vaccine and were determined to most likely have died because of the vaccine caused myocarditis. So let's start our discussion. So this is Drbeen.com. In the description of this video, there is a link that would give you access for a one-time fee of a very low amount to all the 900 premium lectures here. This is the study that we are talking about, this one. So this study is autopsy-based histopathological characterization of myocarditis after anti-SARS-CoV-2 vaccination. And there are some supplementary material over here. There are some other definitions that I wanted to have in front of us. Then this is also another definition of asystole that I wanted us to have. And here, if I go to the top, you would see, okay, so never mind, there was something over here that, oh, all right, so here, the asystole as part of the diagnostic criteria for myocarditis related issues. So these are the references. They are present in the description of this video as well. And now let's go over this data together. So these are our gifts for humanity. They are continuing. The abstract of this presentation of this study is the following. They actually, within one hospital system, they received 35 individuals who died within 20 days of receiving messenger RNA vaccine. 10 were determined to be not related to this criteria, so they were excluded. Out of them 25, 5 individuals who died within 20 days of receiving messenger RNA vaccine were determined to have died because, most likely because of the vaccine caused myocarditis, because these individuals had no other pathology that should have caused this kind of death. So 4 patients had acute epicarditis myocarditis without any other disease, or pathology or constellation of problems that could have caused unexpected death. 1 patient actually had a very similar pathology like the other 4, but this 1 patient also had a low-level viral human herpesvirus presence as well. So that kind of puts their death or myocarditis in doubt that must be because of mRNA. So this is potentially mRNA, but there was another causative agent as well. The histology, that is looking at the cardiac tissue under the microscope, the histology showed, and remember they are looking at the autopsy, so the patient has actually died. So histology showed patchy interstitial myocardial T cell infiltrate. What does that mean? We'll actually discuss a little more later on too, but here within our summary, patchy means small areas or focuses instead of the whole heart. Patchy interstitial is between the cell, amongst the cell. Imagine the cardiac cell and other cells of our body being little houses. Then the roads and streets will be interstitium. So interstitium is outside of the cell. All the tissue spaces collectively are interstitium. So patchy interstitial myocardial T cell infiltrate. So in those roads and streets between the cells, there were lots of immune cells that have invaded, that had arrived there, that had infiltrated there. That is a problem because when they'll come in there, they'll start causing damage. And this infiltrate, the type of cells, immune cells that had gathered there, were predominantly CD4 associated with myocyte damage. And I'll explain. Some of you who have been with me for some time, you will be thinking about CD4 and saying, well, the CD4 has to either trigger CD8 or B cells. Why are we talking about CD4 causing myocardial damage? And I'll explain that a little later. But here, just this much, that the infiltrate of the immune cells was predominantly CD4 cells. The other important thing that is a takeaway from here, from this study, is that the cause of death, the cause of heart stopping, was not the extensive damage to the muscle itself. The muscle damage actually showed patchy focus areas, smaller areas. So if you look under a microscope, you might say, well, these are smaller pieces of damage. Why did they cause a cardiac issue and even up to death? And the researchers addressed that in two ways. One, they said that sometimes the functional problem, imagine for a second that your finger has become injured at a joint. So that injury might look actually small, but you may not be able to move your finger. So when the heart muscle is getting damaged, it may not show a huge big wound, but it may still not be able to function correctly because of the injury or inflammation. Secondly, researchers thought that most likely cause of death seems to be arrhythmogenic cause. That is, instead of the muscle getting extensively damaged and stopping or not functioning, it is probably the electrical wiring of the heart that became disturbed or that became abnormal or diseased, which caused arrhythmia, fibrillation. So eventually the cardiac electrical system did not work, and either the heart stopped, asystole occurred, asystole means no beat, or the heart went under fibrillation. Fibrillation is a very fast movement and contraction of the heart muscle cells independent of each other's activity. Normally the whole heart, let's say the whole atria, they contract as one big unit. So all the cells, microscopic cells, contract together to create one macroscopic big movement. Similarly, all the cells in the ventricles, they contract, and right ventricle separately and left separately, they contract together as one big unit. But if these cells, they start contracting separately without regard to what is the state of the other one, then eventually they do not have collectively any work done. And that would cause the heart to not be able to pump. Although the cells are fibrillating, they are moving, but they're really not doing collectively any function. And that also causes cardiac failure. So researchers thought that the most possible reason of the cardiac failure and death was arrhythmogenic death, afibrillation. And that is a very sad event, because patient just, as they talk about a couple of patients, in one case the patient said, I'm nauseated, and the next moment he was dead. So it's not a good way to go. So the mechanism, we're still on the summary, mechanism of the death. So the question, how did they die? So one, I just explained that researchers, they actually, if you look at the paper, they're not very clear for what was the mechanism, exact mechanism or exact pathology, what caused the infiltrations, other than it was very near the vaccine and there was no other reason. So it is vaccine caused most possibly. But what exactly happened? Was it the spike protein, or was it the autoimmune disease, or was it the vaccine coming through the veins into the heart tissue? They speculated for all those things. But eventually arrhythmogenic death is what was their conclusion. They also said that it is known that vaccines cause, especially the mRNA vaccine, and we have discussed it, they cause robust receptor binding domain specific antibodies. We know this, and that is the function of the vaccine, to produce neutralizing antibodies. Plus, there is a possibility of T cell reaction even at the site of the vaccine administration. And then, in case of SARS-CoV-2, for example, there can be cytokine storm as well. So there is an involvement of immune system more than desirable in some cases. So they said this may be happening here as well. So what they said was, or wrote, they said the CD4 cells, CD4 positive, and I'll explain that again. CD4 are the helper T cells. CD4 positive T cells are the main drivers of autoimmunity in myocarditis. So patients who have myocardial inflammation or heart muscle cells inflammation, in there the CD4 cells are the predominant drivers. This is very important to keep in mind, because normally either it is the innate arm cells, macrophages, that are causing the damage, natural killer cells, macrophages, neutrophils, or on the adaptive arm side, there is either the CD8 positive cells, which are cytotoxic T cells, or B cells making antibodies, and antibodies then causing inflammation. So they are ruling them all out. Actually, in their study, they find some macrophages to be present, but primarily CD4 cells, the helper cells, whose job is not really to cause inflammation. They were doing the damage, and I'll explain why. So then they say that vaccine-induced immune response, CD4 T cell activation, causing myocarditis, and then leading to the death, as I discussed before. Now they said they found that the foci of damage were mostly or predominantly on the right side. And from there, they said there was another study that showed that if you inject the vaccine in a vein, that causes the vasculitis or damage to the heart as well. So maybe because the right heart is the one that receives the blood coming back from the body, including where the vaccine was injected, so maybe that blood that is coming back received or brought the vaccine in the heart, and that will come into the right heart, and that is why the right heart has a problem. Although I tend to have doubts, and they are also said tempted to speculate. They didn't even say we speculate. They actually had two doubtful terms in there. It is tempted to speculate that this may be. The reason for that is that when the heart is receiving blood, other immune-related cells will also come through the veins into the right heart, and then from there they will go to the remaining part. So predominantly right heart can be involved with or without vaccine reaching there, because even the other immune system cells will reach through the same pathway. It's not that the other immune cells will enter through arterial system from the left side. They will have to come in from the right side as well. So I'm not very much sure about this statement of them, but anyways, that is a statement they made. Another thing that they said that was really interesting is that they said, finally, as adenovirus-based vaccines or vector-based vaccines, if you look into their study, they are not associated with myocarditis. That means it may not be something to do with the mRNA, the spike protein itself, for example, or the autoantibodies against the spike protein. They said it may be something specific to mRNA vaccines, and that may be the mRNA itself against which the body is making antibodies, and then those antibodies are also attacking our heart tissue, or there is mimicry that is occurring. And also, as the body is targeting mRNA, maybe that is what is causing immune system activation, which in turn, instead of sending the antibodies, sending the cells out to heart as well, causing damage. Or they say maybe other parts of the mRNA vaccine. So they're not very much clear, and that is not a slight on them. They are actually researchers who are saying, hey, in the autopsy, we are seeing these cells but that doesn't mean we know exactly how the cells arrived there. We know exactly what antibodies did, what B cells did, and T cells did. They said we see the cells standing here. Here are the ones that we are seeing. So before we look at the study and the diagrams that are presented for histology, I wanted to also share some of the uh, pathological aspects that are present. So here I'm going to introduce to you a CD3 positive, CD4 negative, and CD8 negative T cell. They did observe CD3 positive T cells that were negative for CD4 or CD8 negative cells. They did observe CD4 positive cells as well, and they did observe some CD68 or some macrophages too. So let's just look at this cell subset first. CD3 positive cells, and let me actually share what study I am going to refer. So here, this is a study. It says CD3, CD4 negative, CD8 negative T cells in inflammation, immune disorders, and cancer. So I have this link in the description as well. I'm just going to put some of the points from this study here in front of us in this diagram. So imagine that this is a CD3 positive, CD4 negative, CD8 negative cell. This cell was supposed to be present in the thymus, and over there eventually either become a CD4 positive cell or a T helper cell, or CD8 positive cell or a cytotoxic T cell. Although it is known, and I just showed you that study, that 5% of the peripheral circulating T cell are double negative or CD3 positive and CD4 and 8 negative cells. These double negative cells actually behave like innate arm and adaptive arm together. So they can actually behave like both type of cells. So they share functions from both arms. And what are the kind of functions? So let's look at them one by one. First of all, these cells have perforins, which is a function of, remember, cytotoxic T cell and also natural killer cells. These cells also have granzymes, which is also in cytotoxic T cells and the natural killer cells. So here CD3 positive cells have granzymes too. And you might remember that what will happen is that when these cells, cytotoxic T cell or natural killer cell or this CD3 subset, when they reach a cell in front of them that has some antigen that these cells do not like or feel that that is a foreign antigen, then they can poke hole in that cell by perforins. That is why the name perforin. They perforate. They poke hole in the cell membrane, and then in the cell membrane they secrete the granzymes in the environment that would go through those holes inside the cell. And granzyme in turn, as you can see here, I've made that in this skull, the granzyme in turn would activate caspases in the target cell, causing the target cell to induce apoptosis and die. So this is how they kill the cells. Cytotoxic T cell do that, natural killer cells do it, and here you're seeing CD3 does it. In addition to that, so this is a very innate and adaptive both function, right? In addition to that, these cells release tumor necrosis factor alpha, which is a function very much like a macrophage. Macrophages are part of innate arm. So here they are now acting like an innate arm cell. These cells also release interleukin 4, which is a CD4 positive cell's behavior, and we know that interleukin 4 will move a immune system response towards antibody production. These cells also produce interleukin 17, which is actually a function of the T helper 17 cells, that they release interleukin 17. They also release these cells interferon gamma. Interferon gamma is released by mostly the T helper 1 cells, right? So the point is, these cells are so capable of performing so many effector functions and activation functions. that when they themselves are present in the cardiac tissue, these cells are sufficient to cause damage to the myocardium or epicardium and cause destruction there. They do not need the help of a cytotoxic T cell, or these cells do not need the help of an antibody producing cells or antibodies to be there. They themselves are sufficient to cause damage. This is the important part. So now, some of the details now. So if you just wanted to hear summary, this was the majority of the summary, and now let's look at some details as well. So I'm going to go here to this study and go to some of their tables and diagrams. So this is a table 1, where they're talking about the criteria that was used to assess myocarditis. So here, category was no vaccine-induced myocarditis. Criteria, absence of myocarditis or myocarditis without temporal association to a vaccine. So temporal association is near the time of vaccination, or myocarditis definitely explained by something else. So in these 5 cases, the myocarditis was temporally associated with vaccine. There was no other pathology that they could detect that would explain myocarditis. So presence of myocarditis with temporal association to vaccine, but presence of mitigating factors, detection of facultative pathogenic infection. So another possibility could have been if the heart had some other bacteria or virus or some other causative agent found there. And in 4 cases, they did not find anything. In 1 case, they did, but that was also in the low numbers. And then here, likely vaccine-induced, presence of myocarditis with temporal association to vaccination event, and integration of histological phenotype, clinical presentation, and lab findings. So here, unfortunately, the patients had died and they had their tissues. So this is table 2. This is actually all the 5 cases. So if you see here, male 46, female 50, female 62, female 75. So 3 females, 1 male, or 2 males. And you can see the age range from 46 to 75, and the type of vaccines they had. Then I want to share this. So if you see here, these pink colors are mostly the muscle cells of the heart. And these little purplish colored cells are the infiltrating immune cells. And these spaces amongst the cells are the interstitium. So this is interstitial infiltrate. If you see here, the diagram B, this is another stain, but still showing the same infiltrating cells. Here, more infiltrations. Here, foci of infiltration. So if you see here, a lymphocytic aggregates in the interventricular septum of case 1 with associated myocarditis destruction. The infiltrate, check this one out. The infiltrate is predominantly composed of CD3 positive lymphocytes, as I just mentioned, and CD68 positive macrophages. In the lower magnification, 2 foci of CD4 positive lymphocytes are also evident. So here, these 2 are in the lower zoom level. They are CD4 positive cells. Then here is another example. Once again, if you see here, inflammatory focus in the left ventricular wall of case 2, left ventricle of the case 2. And now once again, you can see the infiltrates present here. This is the jab site in the deltoid muscle reveals focal inflammation. So the other thing they wanted to connect was that the type of inflammatory infiltrate that we are seeing in the deltoid muscle and the inflammatory infiltrate that we see here, or immune infiltrate, are very similar. And I would suspect that they should be similar because at the end of the day, that is an immune response. An immune response does carry similarity because at the end of the day, the cells are very similar. The only difference is here you see the bigger patches of them, so more inflammation here and then some inflammation in the heart. Now, when I say some, that is not to light the situation, because this some infiltrate actually ended up causing the death of the person. And that is what I explained in the beginning, that in the diagrams, these infiltrates may look smaller, but cardiac function, and especially the electrical wiring function of the heart, became so abnormal that the patient actually died of asystole, that is no electrical activity at all, and the heart is not beating, it is flatlined, or arrhythmias, where the electrical activity is just gone haywire and the whole system is just running by itself. Each cell is doing its own thing. This is the deltoid muscle, and so on. So then I want to read some of the things that they wrote, which I think are very interesting. They say here, as well known from myocardial infarction, it has to be considered that microscopically visible manifestation of myocardial damage under such acute conditions may lag behind function. That it is possible that heart's function starts dropping, starts becoming abnormal even before large chunks of microscopic damage are seen. This may relate to aspects of infiltrate composition, such as the relatively low macrophage content or the histologically focal myocyte damage. What are they saying here? If there is a lot of macrophages that come over to a tissue, they would cause a lot of destruction, and you'll see big destruction first. But they are saying that in these cases, cases of myocarditis, macrophages were less. Because of that, tissue damage was less, or that evident destruction was less. Thus, functional effect may be much stronger than expected considering the histological picture. So they're saying that histological picture may be showing less of a problem, but functional effect was greater. Then they're saying, in general, a causal link between myocarditis and anti-SARS-CoV-2 vaccination is supported by several considerations. So what are their reasonings to be able to say this was caused by the vaccine? Number one, a close temporal relationship to vaccination. So time frame was close. So there was a person who died the same day of receiving the vaccine, other within 20 days, but really 2 to 3 days. I believe the mean time was 2.5 days. Absence of any other significant pre-existing heart disease, especially ischemic heart disease or cardiomyopathy, negative testing for potential myocarditis causing infectious agents, and presence of peculiar CD4 predominant T cell infiltrate suggesting an immune-mediated mechanism. And I remember I had been discussing the immune-mediated mechanisms since 2021, January, February, that this is a immune attack on the heart more than just the spike doing it, or more than vaccine just itself. So then they say the later criterion is supported by demonstration of phenotypically identical T cell infiltrate at the deltoid injection site. So they're saying that because in the deltoid muscle we are seeing a similar immune composition, then it must be, as that composition in the heart is similar, it must be vaccine related. It has to be emphasized that a comparable myocardial infiltration was neither found in any of the other 20 autopsies performed on bodies found dead within 20 days following an anti-SARS-CoV-2 vaccination, nor in the age and sex matched cohorts from 3 independent periods from our autopsy files. So they said the remaining 20 people who also died after receiving a vaccine within the 20 days, they did not have this. These, unfortunately, 5 individuals did. Then, as I said before, from a functional point of view, the heart failed first, even if the histopathological damage was not too large. Myocarditis-related acute cardiac arrest due to either asystole or ventricular fibrillation is a well-established pathomechanism in other causes of acute myocarditis as well. So that's what they are thinking, instead of saying that the heart just punctured or ruptured, or the heart tissue just inflamed and became so swollen that it would not just work anymore. Then they say our study has limitations, and those are small cohort size and inherits the bias of an endpoint analysis. So the death is an endpoint, and they are analyzing that. So there is no match there. So there is a bias in there that they are already dead because of this, or possibly because of this. The nature of our autopsy study necessitates that the data are descriptive in quality and does not allow any epidemiological conclusion in terms of incidence or risk estimation. So they're saying that from this data, we cannot infer or conclude that, let's say, every 5 people out of 20 who died are because of the vaccine issues, or the epidemiology of the mRNA based myocarditis and death. So they're saying we cannot conclude that data. We can just present what we are seeing in terms of histology, so that more studies can be done, more similar histology, if seen, can be then connected to vaccine. The reported incidence of epimyocarditis after vaccination is low, and the risk of hospitalization and death associated with COVID-19 are stated to be greater than the recorded risk associated with COVID-19 vaccination. So here, I think this is that standard statement they have to add, that, hey, even when we are presenting you this data, it still is that COVID causes more damage than the vaccines. So if you see here, they did not say we believe it, or they said it is stated to be greater, and they then connected to a study. Importantly, infectious agents may also cause lymphocytic myocarditis with a similar immunophenotype. Thus, meticulous molecular analysis is required in all cases of potentially vaccination-associated myocarditis. Then they say, regarding a potential autoimmunological mechanism explaining the myocardial damage, histological examination of lymphocytic nodes might be of interest. So they're saying that the local nodes, lymph nodes, might be of interest as well. Because remember, we actually discussed that study that the local lymph nodes after the vaccination show mRNA-related activity even up to 4 months, I believe. So that's what they're saying, that should also be germinal center, which is part of the lymph node. Analysis must be done. Then they say, finally, we cannot provide a definitive functional proof or a direct causal link between vaccination and myocarditis. Further studies and extended registry are needed to identify persons at risk for this potentially fatal adverse effect, and may be aided by detailed clinical, serological, and molecular analysis, which were beyond the scope of this study. Considering that this fatal adverse event may affect healthy individuals, such registry and surveillance programs may improve early diagnosis, close monitoring, and treatment. This is exactly what I used to say, that when people would criticize me, that why do I talk about vaccine-related thrombosis, that is the first things that we saw with the adenovirus-based vaccines, I used to say that this discussion would help us figure out the protocols to engage, how to look at a patient's state, what symptoms they should be aware of. Doctors should know exactly what to do instead of this kind of an outcome, unfortunate outcome. I guess we are still in the same state. So with this, thank you very much for your time. Please like, subscribe, and share. There are links in the description. If you would like to support this work, you can buy me a coffee, or you can use PayPal, or you can become a member of Patrons, and even buy YouTube membership. I am planning to do a regular chit chat on a weekly basis with patrons and supporting Cool Beans. The reason for that is that I need to be able to sustain these talks. So with this, thank you very much. Please like, subscribe, and share, and I would see you again.